Process of Human Diseases 1. This is Unit 6, Fluid, Electrolyte, and Acid Base Imbalances. So first off, we have to talk about what fluids do in the body. They're very important on a bunch of fronts. They provide lubrication, so in the case of synovial fluid in joints, they allow lubrication, they allow movement of joints. They allow some cushioning as well. All the chemistry in physiology is wet chemistry. Chemical reactions need to be in aqueous solution in order to happen. So all of the chemical reactions in the body in metabolism happen in water. Water is used to transport oxygen, nutrients, waste products, hormones, all kinds of things. And they're also used in regulating body temperature, like bringing blood to an area warms it up. Taking blood away from an area prevents heat loss. So now, where do we find this fluid that's in the body? We're going to find it in basically two main compartments, inside the cell and outside the cells. So intracellular is the ICF. It's the fluid that's found within the cells. It's the cytoplasm of the cell. It's very straightforward. It has its own ionic compositions, as we discussed in AMP1. There is relatively less sodium and there's more potassium. It makes up about 2/3 of the fluid space of the total body fluid in an adult. It makes up less than 2/3 in infants, and that's mainly because infants have more extracellular fluid. So on a ratio basis, it's different. Really, each cell has the same amount of cytoplasm, or relatively the same amount of cytoplasm, adults to children, but it makes up less because children have more in the extracellular fluid. Now, the extracellular fluid is about 1/3 of the fluid in adults and more in infants. Infants tend to be a little dewier, a little more damp. And there's 4 fundamental types of extracellular fluid based on where you find them. There's the interstitial fluid, which is all the fluid that's between the cells. It's just interstitial fluid. Now, there's fluid found in the cardiovascular system, and that's called intravascular or just plain vascular fluid. There's the fluids that are contained in the dense connective tissue and bone. Those are wet tissues as well. There is a question as to whether that would really be deemed interstitial. But it's found in dense, so there's really very little space. So it's the fluid that's kind of incorporated in that dense connective tissue. And the 4th type is called transcellular. It's found in different compartments within the body. So these would be like the aqueous and the vitreous humor of the eyeball. This is the synovial fluid in the joints. This is pleural and pericardial and peritoneal fluids found between the serous membranes. Stuff like that. Now, all of these things have different components. For instance, intravascular fluids have more proteins than the interstitial fluid. We talked about this when we talked about capillary exchange and about edema. Edema really is fluid leaving the intravascular space and moving into the interstitial space. When we talked inflammation earlier, that's what we were talking about. Third spacing is is a term that you'll come across every now and then. It's a clinical term. It really talks about the transference of fluid from interstitial or intravascular into those transcellular compartments. So it's really like somebody with portal hypertension and liver disease will get ascites, a buildup of peritoneal fluid. Sometimes people with heart conditions will have pericardial effusions or pleural effusions. This is a movement from the interstitial or the intravascular space into the transcellular space. Now, the important thing about that is that the body weight doesn't change when fluids go into the third space. It's just a reassignment of where that extracellular fluid is found. And so you don't notice it when you are looking at the body weight. Whereas hemorrhage or a loss of fluid, dehydration, will reflect in weight loss. Third spacing doesn't. Okay, so now fluids move between these compartments. They move between the intracellular and the extracellular compartment. They move between the vascular compartment and the interstitial compartment. They move into the transcellular compartment and out of the transcellular compartment. Cerebral spinal fluid, humors of the eyes, all of that are constantly being renewed. Those fluids are constantly moving into those spaces and then moving out of those spaces at about the same rate, so that there's a constant amount there. So what moves this? It's basically some sort of combination between hydrostatic pressure, the pressure that the presence of the fluid has, which is a diffusion. So fluid moves from areas of high pressure to areas of low pressure. That's called hydrostatic pressure movement. And the other thing that moves it is osmotic pressure. And osmotic pressure is when fluid moves from an area of low concentration of solutes to an area of high concentration of solutes. It's like it's diluting the solutes. We examined this in the lab in AMP1. Now, to go from the extracellular compartment to the intracellular and back, it's primarily osmotic pressure. And it's the balance is maintained by maintaining balances of ions, and that's maintained with ion pumps. And so as long as the cell is healthy and maintaining its correct ion levels, then we will have the correct osmotic pressures, barring any other changes in the extracellular compartment, and the cells will have the right amount of fluid. And it's not always the same fluid. There's always an exchange, so that fresh fluid is coming in and old fluid is going out, carrying waste, fresh fluid carrying nutrients. That exchange is an important exchange. Between the interstitial and the vascular compartment, it's hydrostatic pressure, blood pressure. Capillary hydrostatic pressure is blood pressure, pushing out of the vascular compartment. There's an osmotic pressure, not very large osmotic pressure, but it adds to pushing out. There's a little bit of interstitial fluid hydrostatic pressure pushing in, but there's a lot of capillary osmotic pressure because of the proteins that are in the vascular compartment that aren't in the extracellular or in the interstitial compartment. So the balance is maintained by the amount of proteins in the vascular compartment creating osmotic pressure and hydrostatic pressure due to blood pressure. The ions in the interstitial fluid having a little bit of osmotic, and pressure, hydrostatic pressure from the interstitial fluid. Now, this comes into play in things like edema. That's why tensor bandages or support hose works. It increases the interstitial fluid hydrostatic pressure and puts that fluid back in the vascular compartment so it can be taken away. So this is just a chart showing that that neonates preterm are a lot of water. Neonates still have quite a bit. Children have a little bit less. Adults a little bit less, and the elderly a little bit less. We kind of desiccate as we get older. Please don't memorize these things, and you'll notice that the size of the figure indicates a large range. So adult men kind of 48 to 70%, adult women 40 to 62 or 63%. Women tend to have a little less water per weight than men because the percentage of fats is higher in women. So fluids exit and enter the body via a couple of different methods. So there's a fluid intake. It comes from drinking. It comes from eating. It can come from artificial sources like IVs. We lose fluid through normal routes. So we perspire. Our breath that we exhale is humid, so we lose water that way. We lose fluid in bowel movements, and we lose fluid in urine, in urinating. We can also lose fluid in abnormal routes like vomiting, stomach pump, drainage tubes, that kind of thing. Burns, where there can be quite a bit of fluid loss through the blistering that bursts. And all of this really has a homeostatic balance. So if somebody is a burn victim and has lost a lot of fluid, they're going to be quite thirsty, and you try and replenish the fluid. Or that's why you give them hydration IVs. Now, thirst, again, as we discussed in AMP, is really a complicated thing. There's a couple of ways that we perceive ourselves as being thirsty. One of the ways is by regulating and looking at the osmolarity of the fluids. As fluid osmolarity changes, and the concentration of extracellular fluid goes up, so that means there's less fluid and there's more solute, then we get thirsty. Now, that could be because there is less fluid, or it can be because there is more solute. This is the trigger of thirst that the bars use to their advantage. This is why they give you peanuts or those goldfish crackers that are high in sodium. Any salty food is going to make you thirsty because it's going to increase the amount of sodium, therefore increase the concentration in the extracellular fluid, and you're going to see that as thirst, which will sell more beer. Now, thirst is also can be triggered by a loss of blood pressure, and specifically blood volume. So if you're hemorrhaging, people that are hemorrhaging feel thirsty. A lot of times that's their main thing. Gunshot wounds often complain of terrible thirst, almost more than pain sometimes. Um, so, and this is really about pressure receptors, so the baroreceptors, and and so the baroreceptors work with the renin-angiotensin system, and then that triggers the sensation of thirst. And I won't go over the renin-angiotensin. We did it enough times in physiology. The last real reason that you feel thirsty is because your mucous membranes get dry. So basically, your mouth goes dry, and that manifests as thirst. So this is an important one because wetting the mucous membranes actually ameliorates the thirst. It makes the thirst better. That way we don't overconsume liquids. If you drank until the osmolarity triggered thirst was satisfied, you would overdrink because there is a time lag between ingesting it and actually getting it out into the interstitial fluid that is being tested. So you would overshoot the mark. So thirst goes away when the mucous membranes are wetted. Okay, so this is a pathology course, so we're going to start talking about some pathologies. So there's pathologies of extracellular fluid. Basically, you can have too much or too little. And it falls into two different categories. So there's imbalances of extracellular fluid volume. Now, these things are called saline imbalances. It's a volume loss or an extra volume, and things are the saline is involved. The amount of sodium in that extracellular is involved. Now, normally, isotonic is 0.9% saline. So that turns into being 135 to 145 milliequivalents per liter. Anything less than that is hyponatremic, and anything more than 145 is hypernatremic. So these ECF volume imbalances are known as saline imbalances. The second category of imbalances would be in the concentration of the extracellular fluids. And these are called water imbalances because there's too much water or too little water. Now, a lot of people can have a combination of these things going on, or they'll have them at different times in a process. So we'll start out with this figure, which is showing an extracellular fluid deficit. So there's not enough extracellular fluid. This is a saline imbalance of not enough extracellular fluid. There's the normal osmolarity of the extracellular fluid, but there's a decreased volume. And so there's a decreased interstitial volume and there's a decreased vascular volume, and it's balanced because the osmolarity is normal. So really this is you're losing water and sodium together. So somehow this fluid is gone, and it's both water and sodium. So what can cause this? This could be things like diarrhea or vomiting, renal disorders like of aldosterone, where you are losing fluid and you're losing sodium, salt at the same time. Excessive diuretic use. It's hard to believe, but some people abuse diuretics to try and lose weight, amongst other things that they do. Hemorrhage can do this. You're just losing fluid. And you're losing isotonic fluid. You're losing the sodium and the water. Third spacing falls into this category too. So third spacing is when this fluid leaves the interstitial space and the intravascular space and goes into the transcellular space, pleural effusions, things like that. So what does this do for us? Like, what are the clinical manifestations of this? Well, except for the third spacing, a big clinical manifestation is sudden weight loss. If somebody's losing fluid here at the extracellular volume deficit, they're going to lose weight. If it's third spacing, they're not going to lose weight because the weight will be contained in the transcellular space. Blood pressure is going to go down because there's a decreased vascular volume. And the heart rate is going to increase to compensate for that. So you're going to see that. And so you're going to see a sign that you see is flat neck veins. The jugular veins won't distend. Basically flat veins everywhere. But it's something that you look for. Syncope. People get lightheaded and faint. Oftentimes they have oliguria. They have very concentrated, very dark urine because the body is trying to retain as much of this as possible. Okay, so the next one is extracellular fluid volume excess. So this is when there is too much normal osmolarity fluid. So it's saline and water. The concentrations are normal, but there's too much fluid. So what's going to cause this? Anything that causes you to retain saline. So a big cause of it is excessive aldosterone secretions. So this could be a problem of pituitary. It could be a problem of adrenal gland. It could be a paraneoplastic syndrome where the tumor is releasing aldosterone. And this will happen. This will be the thing. Another common cause of this is excessive IV fluid introduction. So things like Ringer's lactate and the isotonic fluids. And this is why you have to so carefully monitor the flow rates of this and input, output, that kind of thing. Chronic heart failure will cause this, as will chronic renal failure. It's because things aren't circulating the way that they are. That chronic renal failure is that it's not being removed. Glomerulonephritis will do this. So glomerulonephritis, itis is inflammation, so that's at the glomerulus. So GFR goes down, which means that more fluid is retained, but it's all fluid. Things like Cushing's syndrome will do this. Cushing's syndrome is increased corticosteroids, cortisol, and that's going to increase that water retention. Corticosteroid, things like prednisone, one of the drug side effects is this. Even to a smaller extent, high sodium, high salt diets can add to this. It's one of the reasons why people with chronic heart failure or chronic renal failure are put on low sodium diets. So you have to be quite cognizant of this. Now, what are the clinical manifestations of this? Well, they're the exact opposite of what we just saw with deficit. It's sudden weight gain, edema. There's a circulatory system overload, so you get like this bounding pulse when you're checking the pulse. You feel this bounding pulse. You have distended veins, especially the jugular veins, especially sitting up. You get crackles in the lungs, so you can auscultate that. People have trouble breathing because the interstitial fluid in the lungs takes up space, and you end up with that almost like a swelling of the interstitium of the lungs. So dyspnea is a big problem. In infants, when you see this, you're going to get distended fontanelles. The fontanelles are going to balloon out. In infants with deficits, you get like a dishing in the fontanelle. So it's basically edema, but it has to do with sodium and water being in excess. And the big thing is that it's a normal concentration, normal osmolarity. Okay, so now we're going to look at the water imbalances. So hyponatremia means that there's too much water for the amount of salt. So there's a decreased osmolarity, osmolality in the extracellular fluid. So this is, the sodium is below 135 milliequivalents per liter. So it's a hyponatremia, too much water. So it's sometimes called water intoxication, or sometimes hypotonic syndrome. So this happens when there's more water introduced than there should be. So a pathological cause of this would be one of my, I think, the best named pathologies that there is. It's called the syndrome of inappropriate ADH secretion. It's when there's too much ADH released, and so antidiuretic hormone makes you not pee, so there's too much, and so you're not producing enough urine and you're retaining water. You're still losing sodium in your urine, but you're retaining water. The aquaporons are open. So this is a pituitary gland disorder. It's a primary disorder. Other places that you can see this happen, oftentimes in marathon runners or guys that work on roofs or in like hot construction places and that kind of thing. If any of you have ever worked in a factory, you probably noticed that at the hydration stations there's often salt tablets. What happens is when you sweat, you lose sodium and water. But if you only replace it with water, you'll start to decrease the osmolality. Over-ingestion of water can do this. Years ago, a radio station, I believe it was in Cincinnati, ran a contest. It was "Don't Wee for a Wii." It was when the Wii gaming system came out and were hard to get. They ran a contest to see how much water you could drink without urinating, and the person that won would win the game system. This woman drank liters and liters and liters of water as quickly as possible because she wanted to win it, and she ended up dying from hyponatremia, from water intoxication. And it's not a very pleasant death. The clinical manifestations in kind of the more mild cases are malaise and anorexia. You get nausea, vomiting, headache. Oftentimes blood pressure goes up a little bit, but mostly what's happening here is the decreased osmolality means that water starts going via osmosis into the cells, and all the cells in your body start to swell up, and your brain swells to the point where it becomes too big for the skull. So it gives us a terrible pressure headache, and it can actually lead to a fatal thing called cerebral herniation, where the brain squeezes out the foramen magnum like toothpaste from a tube, and it can be fatal. People get confusion. Nervous system things don't work. They go into seizures because skeletal muscles don't work properly. They can end up in a coma. What happens here is, as the decreased osmolality, there's a decreased amount of sodium outside the cell, decreased concentration of sodium outside the cell. It moves the resting membrane potential of the excitable cells, of neurons and muscles, closer to threshold, and so they will fire with less stimulus. They will reach an action potential easier and sooner. So nerves overreact, muscles overreact, and you end up with seizures. And is quite serious and potentially fatal, especially when you start looking at cardiac muscle or respiratory muscles, things like that. So in the severe cases of this, there's a lot of ways to die. Okay, so another water imbalance is hypernatremia, and the cells shrivel. And it's because there is an increased osmolality in the extracellular fluid. So osmosis works against the cells. This is hypernatremia, anything above 145 milliequivalents per liter. It's also known as a water deficit or hypertonic syndrome. Hyperosmotic syndrome is sometimes called. It happens just for one of two reasons. One, that there's excess of salt introduced, or there's loss of water without losing the sodium. So this is in contrast to losing sodium and water. This is just losing water. And this is why these are water imbalances and not really sodium imbalances. I find that terminology a little bit confusing and not very satisfying, that hypernatremia is a water imbalance and fluid excess is a saline imbalance, but go figure, that's the way it is. So really it's the opposite of that hyponatremia thing. So anything causes excess sodium, anything that causes a loss of water without losing sodium. So there's all kinds of reasons for this. Table 24.4 in the textbook lists a whole bunch of them. anything that inhibits antidiuretic hormone, like alcohol consumption, can do it. So, in a way, it's a little bit hypernatremia is a hangover. Um, Concentrated tube feedings are a real thing. Like if introducing too much concentrated nutrients in a tube feeding without enough water can lead to this. This is a very real nursing issue. So some of the clinical manifestations of this are confusion and lethargy. And you can imagine that neurons aren't firing as much because you're moving away from threshold in the with the amount of sodium outside versus inside. So you're moving away from having those action potentials. Coma, seizures. Oftentimes there's thirst and oliguria. Now, you got to be careful about that because that's also signs of a saline imbalance as well. But it could be either. The cells actually start to shrink, and so that's that has its own manifestations. The cells don't work properly, and depending on what the cells are, they're just not going to be as efficient. Okay, so now the last couple of things that we're going to look at are mixed categories of this. So the first one is clinical dehydration. And clinical dehydration is really a mixture of a volume deficit and a hypernatremia. So there's a deficit in volume and there is an increase in the amount of sodium. So it is a water imbalance and a saline imbalance at the same time. So what can cause this kind of thing? People that have like an enteritis or a gastritis where they're vomiting and having diarrhea at the same time and they don't replace the water and the sodium. This is a very common thing, food poisoning and that kind of thing can cause it, and people can get quite sick and they can become clinically dehydrated from it. Now, the clinical manifestations are found in box 24.5 in your book, so I'll let you look at that yourself. Okay, so the next mixed one is edema. So this is a saline and a water issue. Now, there's a bunch of different kinds of edema, and they can be caused by a number of things or a combination of these things. So in this figure, it shows the normal capillary filtration, the osmotic pressure in of 25, the hydrostatic pressure out of 35 at this end and 15 at that end, the interstitial osmotic pressure and the interstitial hydrostatic pressure are the four forces that balance and homeostasis is achieved. So basically, because there's four forces, we can end up with about 4 different types of edema. So a real common one is increased hydrostatic pressure in the capillaries. So that's anything that increases blood pressure. This is hypervolemic blood, so there's too much blood, too much liquid. Vasoconstriction can cause this. Anything that's going to increase this capillary hydrostatic pressure, and because what will happen is more fluid will push out and it will cause an imbalance with the forces that are pushing fluid or pulling fluid into the capillaries, and so we end up with more in the interstitium, and that's edema. Another very common thing is increased interstitial osmotic fluid pressure. Normally this is very low because there's all kinds of proteins that are found within the blood. Albumin or albumin is the main one, and it causes capillary osmotic pressure. But as we know, in the inflammatory state, proteins leak out and proteins go into the interstitium, and that will increase the interstitial fluid osmotic pressure, which will draw fluid out along with the hydrostatic pressure, and we'll end up with more interstitial fluid, edema. Now, the balance of all of this is that in normal conditions, there is more fluid put out at the arterial end than is brought back to the capillary at the venous end. And that excess fluid is picked up by the lymphatics, and lymphatic drainage is responsible to maintain that balance and return it to the bloodstream. Now, there are a lot of things that can block lymphatic lymph node issues, remove lymph nodes surgically, in cases of breast cancer, tumors, all kinds of things can block lymphatic flow. And lymphatic flow is an important adjunct to maintaining this balance. So you block the lymphatic flow, and areas distal to the blockage end up with edema. It's not systemic, it is just distal to the blockage, so it's very easy to recognize. You will often see, especially in patients that have had breast cancer and breast cancer surgery, where they remove lymph nodes and looking for the sentinel nodes, they end up with lymphatic drainage problems, and the one arm on the side of the surgery will be significantly larger and edematous compared to the other arm. And last but not least is decreased capillary osmotic pressure. So anything that causes an inappropriate, a not enough albumin in the blood will lead to this. So albumin is made in the liver, so people with liver disease, people that abuse alcohol, people with kidney disease, and they're losing albumin in their urine, so there's proteins in the urine, can end up with this. And what happens is not enough fluid is brought back to the capillaries, so it stays in the interstitium and becomes a edema, and it's systemic. It's body wide in this case. Now, this is important because it's indicative of a lot of different things, but it's also important because clinically, a lot of times when there's edema, especially systemic edema, they throw the diuretics at it to try and decrease capillary hydrostatic pressure, but that just won't work if there's not enough albumin. So this is a topic of discussion with the other nurses and the doctors when dealing with a patient. Okay, so now electrolyte homeostasis. Really, electrolytes are salts that are ionized. They're found in water. So these are things that are held together by ionic bonds, and the ionic bonds are broken, so we have charged ions. Cations are positive charge, anions are negative charge. And we take in electrolytes, food, drink, IV, sweat, we lose electrolytes. We can lose it through urine, through diarrhea, through vomiting, through drainage, that kind of thing. Now, in the previous section, we talked a lot about sodium, and sodium is an electrolyte, but there are other ones, potassium, magnesium, calcium, various things like that, and they all have their homeostatic imbalances. Okay, so I mean, all of these imbalances can be really summarized in the table that's in the blackboard in this unit's contents, right next to the link to this video. So please look at that table. That summarizes it nicely. So there can be all kinds of things going on. So like magnesium is involved with acetylcholine and the neuromuscular junction, and so it manifests. The clinical manifestations are there as well as other places. So when we look at the electrolytes, they are the ionized salts, the cations and the anions, as I've said, dissolved in water. And the normal concentrations are exactly what you see here. It's probably a good idea to be familiar with at least these main five, because these are the ones that we have the most clinical problems with: sodium, potassium, calcium, magnesium, and phosphates. And you'll notice that they're all milliequivalents per liter except for phosphates, which is in milligrams per deciliter. All that is the way that they test it. Now, as I said before already, that electrolytes come in, they have to be brought into, ingested, and then they have to be absorbed. And sometimes absorption is a problem with things. Like, for instance, calcium needs vitamin E to absorb. So you can ingest a lot of calcium. Without vitamin D, you just have calcium-rich poo. So you need both in a way of ingesting it and getting it into your body. So that's absorption. Or you can take it parenterally. So you can IVs and that kind of thing. So you can bypass the digestive system and introduce electrolytes. So a lot of times that's what happens when people are have an IV bag hung. It's about electrolyte balances. Tube feedings, as we already said, can be a way of putting in electrolytes. Lungs near drowning, so especially in salt water, will bring a lot of electrolytes into the body. Skin not intact, things can get in. Salts and especially if you're cleaning it in salt water, potassium, magnesium in seawater. That's a legitimate way of actually increasing. When you look at the small amounts of concentration, it doesn't take very much to change it. So as we saw in anatomy, electrolytes are distributed in the different compartments. They have different concentrations of it. For instance, sodium is found extracellular and potassium is found primarily intracellular, etc. So have a look at that stuff. We get rid of electrolytes through urine. Sodium, potassium, we excrete potassium if there's too much into the urine. The sodium potassium pump and aldosterone deal with that. Diarrhea, we lose potassium and magnesium a lot because undigested fat binds with both calcium and it's saying potassium, but it binds with calcium, magnesium, and potassium. And you lose it all in the feces. It passes too quickly through and you don't absorb it. Sweat, you lose electrolytes, primarily sodium and chlorine. And there's the abnormal routes. You vomiting, emesis, um, dialysis, wound drainage, fistula drainage, things like that. Any place where you're losing fluids through abnormal routes, whether it's on purpose or by accident, will you will lose electrolytes. Even hemorrhaging for that matter will do it. So there's a table on page 536 that looks at the signs and symptoms of the fluid and electrolyte balances. And there's a table posted on Blackboard that does the same. It's a little more succinct. So have a look at those things, and that's it for electrolyte imbalances for this unit.